Gentry, which I'll do as soon as I can see my speaker notes on my phone. Okay, so we're joined today by two leaders that'll not be strangers to many of you from Northeast Georgia Medical Center, where both the mother, baby, and the NICU have been active participants in the Optimizing Newborn Nutrition Initiative. For these several years. Dr. Aubrey Williams has 15 years of experience working in NICUs. She is certified in obstetric and neonatal quality and safety, nursing professional development, high-risk neonatal intensive care, and is a medication-assisted treatment specialist. In her position, she works alongside her staff, but also works with the local universities, regional hospitals, community first responders, and community organizations to improve the quality of care for neonates and their families. And just as a fun side note, some of the pictures of infants that you're going to see in the slide deck today are Aubrey's twins, who were born at 34 weeks gestation and spent some time in the NICU with her coworkers. I'm also pleased to introduce Gentry Hunt, who's currently the Director of Mother Baby, Pediatrics, Women's Health, and Lactation Services at Northeast Georgia Health System. With more than 20 years of experience as a nurse, including 13 years in management, she brings a wealth of knowledge and expertise to her role. Her passion is identifying gaps in practice and innovative solutions. That's very fitting for today's topic. Gentry is also pursuing her Doctor of Nursing Practice, her DNP from Capella University, further expanding her skills and qualifications. So we're really happy to have these two very qualified folks here today. Our learning objectives for today's talk. First, we'll define pasteurized donor human milk and its role in term newborn care. I know we've talked a lot about using pasteurized donor human milk in the NICU, but we're going to be looking also at how it could be used for term babies. Or rather, we've talked a lot about its use for preterm babies that are in the NICU, but we'll also be talking about term babies. Next, we'll look at clinical scenarios that warrant its use. We'll discuss barriers to implementation of this kind of program. And finally, we'll talk about solutions and best practices. So, why the first few days of breastfeeding matter? I think a lot of you guys could answer this question if you've been attending this 3-year-long series of webinars, but we'll just first call to mind the idea that the first few days of life are important in terms of establishing milk supply, and early feeding has profound long-term impacts. Early formula supplementation is associated with a change in the gut microbiome, reducing breastfeeding duration, and there's some in the literature about increasing food allergy risks. We also have spent a lot of time talking in our many webinars about establishing lactation in the early postpartum period. So the first few days are really critical for that, helping meet the family's feeding goal if they want to be breastfeeding. So as we talk about pasteurized donor human milk being a bridge, which we'll get into, first, why is it important to consider using pasteurized donor human milk if supplementation is necessary? So if you haven't ever seen the webinar from our late and beloved colleague, Allison Rose, that we did early in this series, she did a whole webinar called What is Donor Milk? Oh, I'm trying to remember the title now. And questions you were afraid to ask. I'm trying to remember if anyone can remember the title, put it in the chat, please. But it was a really good comprehensive overview of what is pasteurized donor human milk, but we know it's milk donated by screened, healthy lactating individuals. It's pasteurized milk from Himbana nonprofit milk banks. It's Holder pasteurized milk from Prolacta is VAT pasteurized, and it's distributed through either accredited nonprofit donor milk banks or for-profit milk processing companies like Prolacta. While it lacks some bioactive components of mother's own milk, especially mother's own fresh milk, which we want to hold as the ideal or standard here, donor human milk is considered superior to infant formula in that it's species specific, it contains the correct balance of macronutrients, but also all those live cells, hormones, growth factors, oligosaccharides. Some of those are affected by the pasteurization process, but it's very gentle. And while it's good at eliminating bacterial pathogens, it preserves a lot of the live bioactive factors in human milk. It's not as good as mother's own milk because it is not specifically made for that infant like a mother's own milk would be. So some clinical indications to consider when looking at using pasteurized donor human milk as a bridge to mother's own milk in term neonates would be babies who dyads in which the mother has risk factors for delayed lactogenesis too. And some of those are going to be pre-existing. And then some of them are in relation to the birth, like hemorrhage. So those maternal illnesses or complications. We know that hypertension and metabolic concerns like diabetes can be, or other insulin resistance can be a risk factor for delayed lactogenesis. So for families in which the maternal feeding goal has been to exclusively breastfeed, but there's a clinical need for supplementation, then it's worth considering using donor milk for the supplementation. So of course, when we have term babies or near-term babies that are separated from their mothers due to NICU admission, we've interrupted the Q feeding, a breastfeeding that's recommended. That frequent responsive feeding that we've talked a lot about is almost impossible when the baby's admitted to the NICU. So that is another reason to consider if the baby does need to be fed right away, that we are considering using pasteurized donor human milk as a bridge, because it's hard to express very much volume of colostrum with a breast pump or even with hand expression in the first few days. And then when the baby has excessive weight loss, hyperbiliary, hypoglycemia, some of the things we've talked about in our other webinars that require supplementation, these are some times that you might consider supplementing with pasteurized donor human milk rather than infant formula. So some of the reasons that you might consider this is that pasteurized donor human milk is, as I mentioned, species specific. It supports gut development. It's immunologically active. It's the nutrients are bioavailable, very digestible, supports gut maturation. It can act as sort of a neutral bridge to mother's own milk. Some hospitals consider using pasteurized donor human milk in order to keep their PCO5 levels of exclusive breastfeeding up high. I think it's important to consider this is still supplementing, and we want to do all the support that we would do when we were supplementing with infant formula as well, in terms of protecting milk supply and making sure that we're connecting families to lactation support. But we'll talk a little bit more about that as we continue. So introducing this concept before we hand it over to Northeast Georgia is that we're talking about using pasteurized donor human milk as a bridge and not as a substitute for mother's own milk. And we'll share some resources, references, and in the follow-up about how using pasteurized donor human milk as a bridge can promote breastfeeding and help families reach their breastfeeding goals when we use it as temporary supplementation to transition to direct breastfeeding or exclusive use of mother's own milk. So I'll pass it off to our Northeast Georgia team now.
Hi, group. So one of the things you said really kind of leads into this slide, using it as a temporary solution. And we'll talk some more about some of those barriers that we have. And that really has kind of been one of them, is helping our providers understand that it should be a temporary solution. But this is a clinical workflow example of how we would utilize donor milk with our term newborns. So if you have an exclusive breastfeeding infant that has a hypoglycemic episode and requires intervention, along with The dextrose gel, we do offer on mother baby the use of donor breast milk as the supplementation. So, the intent and the hope is that mom is well educated on the choices that she has. And if she chooses to use the donor human milk, that's what we will do for that hypoglycemic intervention. Along with that, of course, you would want your lactation consultants to be there to support them. So ensuring that you have a consult entered and getting them to the bedside to help provide that support is vital. So this is just one way that we would use that donor milk on mother baby. You would also want to make sure that you are tracking this use using your nutrition management systems that you have in place. Another important key is really outlining the criteria of what is medically necessary when it comes to hypoglycemia, weight loss, all of those things. So this is just an example of how we utilize that for our term newborns. When you talk about challenges, and we'll get into this a little bit more in detail in the following slides, but really just that lack of awareness or education, maybe cultural or personal beliefs, maternal perception, provider skepticism, and then there's also the cost concerns, limited supply, especially and not all hospitals have this available. The consent process, misconceptions that it's only for NICU infants. And then as we all struggle sometimes with the constant change, just resistance to any change in those processes. So institutional barriers, when you're talking about cost and reimbursement challenges, which this has definitely probably been one of our biggest hurdles, is meeting with all those different key players, the coding departments, billing, IT, how do you integrate this into your EHR? How do you receive reimbursement? Understanding, is it worth it? You got to look at all of that, all of the cost that goes in to each of those pieces. And then also, do you have support from your institution for the reimbursement process? It's a tricky one to get reimbursed for, just due to the way that we are used to charting and the way that they pull the quantity to reimburse. So that is definitely a hurdle that we've still been fighting. When you look at hospital policy, you want to make sure that you have a policy in place before you just put the product out there. Again, since it's such a financial investment by the facility, you want to make sure that you have that policy in place so that you have some parameters around it. And then you also want to make sure that you're including donor milk into your existing policies, like the feeding policy, your hypoglycemia algorithm, and then thinking through who is ordering, who's receiving, how are you going to store it, how are you going to prepare it, and who's going to be kind of those champions for administration of donor milk and the term infant. Because like you said, a lot of times it has just been perceived as being utilized in the NICU setting. And then competing priorities within your perinatal units. So does everyone have the same priority around infant nutrition? Are your providers more willing to leave infants on IVs to ensure that the first feed is human milk for those babies that are in the NICU? Are they encouraging that skin to skin? Who really just have to understand where everyone is, meet them where they are, and then try to educate everybody to a point of being ready to really move forward and accept change with this. Specific to providers, some of the things that are common, just knowledge and education. Maybe they're not up to date on the research of using donor milk in term infants, the benefits in hypoglycemia management, reduction of formula exposure, and really just that promoting of exclusive breast milk. Perception again as only being used in the NICU. They probably still, a lot of them probably still associate it with the very low birth weight, preterm infants, and they don't really understand its broader clinical applications. And then sometimes, just the lack of clarity with guidelines, protocols, order sets. Sometimes there's just a lag of understanding all of those changes. Belief-based barriers, I think we've all seen over the years a bias towards formula, viewing it as equally safe and effective. I do see in our organization, we're starting to see a little bit of a turn there as far as that perception. And so I think that just takes time to really bring that education up to where it needs to be. And then sometimes even those that are really pro breastfeeding, they may feel like giving donor milk may interfere with that maternal milk production. And so also they may have risk and liability concerns, safety, legal, ethical concerns. So if you head down this road, you definitely want to make sure that you're working with those departments, making sure your consent is properly done, and getting all of that squared away, or you may not get provider level buy-in. And again, something we all struggle with still, and you'll see this come up time and time again, just that change resistance and the culture, which we all know takes time to work through. With lactation, I think that they want to support this. I have seen tremendous support within Northeast Georgia, sometimes with the lactation consultants stepping in, helping the bedside mother-baby nurse, really advocating to properly educate mom. And so sometimes it's a challenge because nights, weekends, holidays, you may not always have lactation, or they may be prioritizing their time more in the NICU. And so there may be a delay in getting to mother baby. And so you really want to just make sure that they're engaged, they understand the process, and that they are on board with supporting not only the patients, but also the mother baby staff, because this would also be a change for them as well. Again, another constraint for lactation, high patient to lactation ratio. And so they may have to prioritize where they're spending their time. And then poor documentation or communication. I feel like this is probably the other biggest barrier we have. Not poor documentation on any one person's part, but when you have the bedside nurses, you have providers, you have lactation staff, there's often a failure to really close that loop as a team and make sure that everyone is providing the patient with the same information, the same plan, and everyone's on board, kind of heading in the same direction. And this is just a constant piece of work that you never really stop trying to improve. The other thing you may come against with lactation is language barriers or cultural misunderstandings. I don't know if there's any other leaders on the phone that have lactation under their oversight or have any input, but I will say that at Northeast Georgia, we do have 3 fluent Spanish IBCLCs, which is a huge blessing, and we continue to try and recruit and retain those employees so that we can avoid the language barriers and help with that cultural misunderstanding. So I would highly encourage that if you are hiring. With parental perception, again, I mentioned it earlier, maybe just some discomfort with utilizing another woman's milk, cultural or personal beliefs that they really feel that associate the milk with maternal bonding. It may just feel unnatural or unsafe. And sometimes that can be rectified with proper education. Again, that bias with formula, it being safer. Sometimes, our patients still view formula as a scientific or advanced alternative, equating to better nutrition. Maybe it's more convenient. They know that they won't have donor milk when they go home, so that might be impacting their decisions. Concern, again, that it might decrease their own milk production. They might become dependent on the supplementation. And even that guilt or shame that we love to do to ourselves as moms of, why do I need supplementation? Why am I not enough? And so really just trying to help the patients work through those emotional barriers and other perceptions with donor milk can be helpful. When it comes to equity and access issues, I did kind of touch on this earlier. A lot of smaller non-academic facilities may not even have access. You may have transport or storage limitations. When it comes to perceptions about cost, there's inconsistent reimbursement. And sometimes that can either equal out-of-pocket costs for the patient or hospital burden if your hospital has taken on that commitment. Medicaid policies that vary by state, hospital level financial prioritization, can they absorb the cost for the benefit, lack of cost effectiveness in preventing complications. So maybe your hospital administration that you're trying to get to approve this don't understand that it can decrease the readmission rates. It can decrease extended length of stay due to weight loss and hypoglycemia and hyperbilirubinemia. So all of those things that you may want to utilize donor milk in the term infant, maybe they don't quite understand that. So making sure that you really show those cost savings for the long term versus that short term impact with finances. And then again, just assumption that it's too expensive, and some patients fear that they may get a bill in a couple of months whenever they go home. So that, I think I'm passing it to Aubrey now, and I look forward to any questions at the end.
There we go. Thanks, Gentry. So what are potentially better practices to support the donor human milk bridging? Possibly even within our NICU, rooming in parents or parent sleep rooms. So what does that availability look like? I know currently on our unit, we only have 2 rooms, so for those transitional patients. So what does that look like? And thinking outside of the box, can you call mother baby or your postpartum or your antepartum unit and have mom room in on a different unit, but still be able to come to the NICU to breastfeed or to help bridge and help with milk supply? Better practices, taking time, which is a big one. So babies are learning how to eat, moms are learning how to breastfeed. So taking time and allowing the 34-weekers to learn how to eat, and might be a little slower to take off fluids or wean off fluids. As you can see here, my kid was here for bilirubin anyway, so my neos actually had the conversation with me of, hey, why don't we focus on breastfeeding? Why don't we can bridge, we can do lots of other things, because they're going to be here with us anyways. And having all providers on the same page for supplementation practices, that is a big deal. And you saw earlier in the slides that Gentry was showing of, we have orders for mother baby. So donor human milk is automatically ordered and allowed for those specific medical reasons. And the comfort level and the knowledge that goes around donor human milk for bridging. So clinical solutions, what do we need to do? We can standardize supplementation protocols, such as on your hypoglycemia algorithm, is donor human milk listed as an option for moms that are exclusively breastfeeding. Also, donor human milk as available as a default for formula when mom is not available. And I know we have, even within our NICU, in our transition area, so when they're not admitted to NICU, but they're not good enough for mother baby yet, or not stable enough for mother baby yet, we what are we doing, and are we utilizing donor human milk as that bridge while they're in transition? And that's an uphill battle for us currently, for full transparency. And then have clear guidelines for use in term neonates. Is it part of your policy? And as Gentry listed before, we had to embed it in each of our policies and procedures so that it becomes part of our full clinical practice and not just a suggestion. For strengthening lactation support, we have something to consider. So we have our infant feeding policy that states we have to have, every single women's and children's employee has to have a certain amount of hours of breastfeeding classes and education. And then we do have annual education as needed for support to continue this. Also, early and frequent lactation consults. And with those, what does the workflow look like? Can a secretary call lactation when a new admission comes into the NICU? Or if a mom is on antepartum, is the antepartum nurse, or after delivery, is the antepartum nurse calling lactation to get them an earlier consult instead of waiting for them to be transferred to mother baby at a later time? And also going back to that train all staff on lactation basics, consider having your newborn admission nurses certified lactation nurses or certified CLCs, because that really helps get them pumping. If the mom is in NICU or the baby comes to NICU, they get the moms pumping early on in labor and delivery, sometimes even in our PACU or in recovery after a C-section. And warm handoff to outpatient support. So for the workflow for moms on mother baby, lactation, they have the lactation information for outpatient consults to contact once they are discharged. But then if baby's in the NICU and mom is discharged at that point, lactation can still see them within our NICU and still see them on an outpatient basis as well. Policy solutions. So I love policies and procedures because it helps regulate everyone's practice. And you have to have policies and procedures in place before you can even fully attempt to get donor human milk in place, because it helps to standardize the care and the practice. We have integrated donor human milk bridge into policies like our infant feeding policy and our hypoglycemia algorithm. It's in our mother baby order set. It's in our NICU order set. We take advantage, policy solutions taking advantage of Medicaid and reimbursement. Like Gentry said earlier, it's all dependent on the organization and what they see as a priority. Our organization, it's a priority to give newborns donor human milk as that bridge or as that supplement. And we can figure out finances on the back end is their take on it. And advocating for that private payer reimbursement, because if only Medicaid's reimbursing but private payers are not, then is it really worth the trouble of building it into our EPIC system for reimbursement and billing and practices? And I did put a snippet here on the bottom of what it looks like in our hypoglycemia algorithm. So supplementation is defined as 5 mL per kilo with a 20 mL maximum of express breast milk, donor human milk, or term infant formula. So we do say that if a mom is wanting to exclusively breastfeed, that's when that donor human milk. But if she has formula as her feeding preference, then the infant is given formula. Communication tools. So develop clear consent forms and handouts. And then also as an organization, when you are implementing this, I know we implemented initially in the NICU. So we had a full informed consent form and refusal form with all of this information to go over and discuss with parents. And it's a mid-level or advanced practice provider consent refusal process. However, on mother baby, and we're trying to get it into NICU, but it's hard to get away from some practices of saying donor human milk is a standard of care. It is an expectation if mom is going to breastfeed or exclusive breastfeeding, donor human milk is a standard of care for that bridging process. So we give informed consent verbally, but it's a refusal form that would be signed if they say absolutely not, or they just get formula. So there really are no forms on mother baby because it's standard of care, and we're working towards that in our NICU, I know. And emphasize the temporary use and safety of it. That's really important because especially for bridging, and you can see in our numbers later on that having this practice and with this newborn initiative, our discharging on breast milk and things like that have also changed. We use more human milk additives and versus just ready to feed formulas. So looking at the evidence, impact and outcomes, and this is with our bridging and along with our newborn nutrition initiative. You can see for term newborns, our numbers of exclusive breastfeeding have increased for Gainesville and Brazelton. And then for NICU, we have increased, and I don't have the, because we use Prolacta, I don't have the specific numbers at the moment, but we have increased our human milk fortifier use instead of using ready to feed options. So with the use of breast milk and initiating it earlier on, we are seeing we're not using ready to feed as much. We are using mom's milk with the human milk fortifiers. And you can actually see our discharging home on EBM have slowly increased as the years have gone on with the newborn nutrition initiative. So considering tracking, and this is for mom baby practices as well as us in the NICU, we do look at supplementation type. We do look at exclusive breastfeeding at discharge on mother baby. We don't do that as much in NICU. We look at discharging home on milk, on breast milk. So are they getting human milk at discharge? Yes, that's awesome. Breastfeeding is a goal, but we want them on human milk when they're discharged. And then lactation consult timing, something to consider. So time from that order and up to that first, when are they being seen first? And donor human milk usage by indication. So what does your documentation look like? Are you tracking it? If there is supplementation, is there a medical reason or is there a reason listed for supplementing in your documentation so that you can track that to see the use of it? For financial considerations, discussing, like we said before, hospital cost versus benefit. I've been in many meetings from a hospital level with the different departments, billing and finances, and even IT. We had it built into our flow sheet rows for billing purposes, but it's the back end of cost reimbursement that the hospital looks at. Cost per ml versus reduced complications, and we have higher patient satisfaction with that lactation support and breastfeeding support. Also financial impacts. So with our our newborn nutrition initiative and breastfeeding initiatives within the Northeast Georgia Health System. We have actually initiated lactation cookies. So patients on mother baby get lactation cookies for pumping, and then we also have a tray of them at our NICU greeter desk, so that they can, as they're coming into the NICU, they can pick up a lactation cookie, and these are specialty made with the recipe from our nutrition department. So they're delivered two times a week, I think, to the units.
And they're really delicious.
They are really good. And then we look at long-term ROI for breastfeeding promotion of supporting patients and their families through their breastfeeding journeys. So, key takeaways. Donor human milk does fill that critical gap when a mom is not yet available. But also not yet available, but also if there are infant medical conditions that require supplementation, such as hypoglycemia, such as infant weight loss, just to help fill that gap until mom is able to produce enough to fully supplement infant. Supports exclusive breastfeeding goals, and I know we work very hard towards that. And it used to be we didn't want to call and wake up moms in the middle of the night to say, hey, baby's hungry. We just go ahead and supplement with formula. But now moms are like, nope, call me. I will be down here every single feed. I will do whatever I have to do to do this. But also when mom is at an exhaustion point, we also use it to bridge at that point so mom can sleep, but also her infant is still getting exclusive human milk diet. And it does have to be accompanied by a strong lactation support. We love our lactation consultants and their diligence and their desire to have everyone on the same page and the goal of breastfeeding for all of our patients. And it does require clinical policy and procedure and cultural strategies to succeed for sure. We had policies and procedures in place for handling storage, warmer use. Do you have the equipment for the warmers? Do you know how to clean the warmers? And everything that goes with it. The storage for it. Is it stored in the NICU and then mother baby comes on and gets it, or does mother baby get their own freezer for their donor human milk? So really looking at all of that.
And Aubrey, I would add to that, just really listening to your staff, roll out your best effort, and then make sure that you check back in with them and make adjustments. It's one of the recent adjustments that we made. We didn't want to really invest in a freezer until we made sure we had the process ironed out and all of that. And so the mother baby staff would have to walk down to the NICU to get their milk. And they reported that as a barrier to why they don't utilize it more often. It just took too much time. So, listening to them and getting a freezer on mother baby. So that definitely was a key takeaway from our implementation.
This was great. Thank you so much. If anyone has questions, please feel free to drop them in the chat, or you can, of course, come off mute and ask them into the room. Thank you so much, guys.
Oh, that was amazing. I'm just looking through to see if anyone posted it.